Good morning. As of today, at 10:30 a.m., there are just under 5,000 people hospitalized with COVID-19 in Pennsylvania. And of course, this number is of significant concern. In addition, there are more than 1,000 COVID-19 patients in the intensive care unit. We have seen that a number of counties in Pennsylvania have only a few intensive care unit beds left, or actually no intensive care unit beds left in their county. As we continue to reach milestones in the number of people hospitalized and hospitalized in intensive care units, it's important to remember that this has a direct impact on the dedicated healthcare providers who are working night and day to protect us. Joining me today is Dr. Ronald Stroney, co-chair of Emergency Medicine for Geisinger Emergency Medicine Institute. He is also responsible for the system-wide operations of Geisinger's Emergency Department and the director of the Division of Emergency Medicine at Geisinger Wyoming Valley Medical Center. Thank you so much for joining us today, Dr. Stroney. Can you tell us how things are at Geisinger?
Thanks, Dr. Levine. Yes, absolutely. I can tell you that just as you described across the state, we're facing the same challenges that everyone is. It's clearly an unprecedented time. I mean, we've made preparations back in April when this first came about, and we've put all those preparations and actions into place currently. But even by doing that, our capacity and our challenges are still under such significant constraints that it's difficult to be able to manage the entire population. The good news is, though, that we are still able to do that. We are still able to stay safe, maintain the population of patients that still need general medical care as well.
And the work of your teams. We know that your schedule is extremely busy, and we appreciate you joining us. And I would really like to say that we thank you and thank all of the healthcare workers at Geisinger and throughout Pennsylvania for their dedicated work to save lives with patients with COVID-19 and for other general medical and surgical patients, as you said. We certainly owe you a debt of gratitude, and you all are on the front lines, so thank you.
I don't think we can reciprocate that enough, and I would echo that statement to all healthcare workers across the state, not just at Geisinger. I think everyone is going through this. It is a very emotional and mentally difficult time for a lot of workers. And what we're doing is we're trying to provide for everyone across the state. So thank you.
Thank you. Since the start of this pandemic, we have worked to ensure that our healthcare systems do not become overwhelmed. As you know, last week I issued an order related to hospitals that will require elective procedures to stop if triggers are met that include staffing, COVID surge, and bed capacity. To date, no healthcare coalition region has met all three triggers. However, the Southwest PA region and the Keystone region coalitions have met the staffing trigger. As a reminder, this means that a third or more of the hospitals in the region anticipate staffing shortages within the next week. To address this, the coalitions are using our healthcare preparedness structure to ensure regional coordination to address medical surge and resource needs at the regional level. And the Department of State and the Department of Health have issued waivers to allow more healthcare providers to provide care in Pennsylvania's hospital. But it is so important to remember that all of us have to be mindful that we all have a role to play in what is happening in the hospitals right now. You might not need hospital care right now. You might not have a loved one in the hospital right now. But what is happening in our hospitals has a direct impact on you. It has a direct impact on the mitigation steps you have to take in order to contain the spread of the virus. It has a direct impact on your community and the healthcare workers who live right there in your area. And it has a direct impact on other healthcare services that you might need that are not related to COVID-19. We are certainly not through this yet, and we cannot return to life as normal right now. Everyone is impacted by COVID-19, everyone. We have to remember that there are not an unlimited number of hospital beds, but even more importantly, there are not an unlimited number of staff, doctors, nurses, support staff, EMTs, healthcare workers in the most general sense. The people who make our healthcare system work are relying on you to do the right thing. We need to stay strong, and we need to stay united and work together for the common good. What this virus has certainly shown us is that we are all interconnected, and we all have a collective responsibility to each other. We are blessed with many freedoms in the United States, but since the founding of our republic, freedoms come with responsibility. Our responsibility to our families, our communities, our state, our nation, a collective responsibility to the common good. And we all must work together and stand united against the spread of this dangerous and contagious virus. And as always, stay calm, stay alert, and stay safe. And now I'm pleased to answer questions.
Thank you, Secretary. Our first question is from Aaron McCarthy from the Philadelphia Inquirer. Aaron, go ahead and unmute.
Hi, Dr. Levine. Thanks so much again for doing this today. My question is related to that order that you referenced last week, and again today related to hospitals and the possibility of state intervention, which would require those elective procedures to be reduced by 50%. Would that directly impact the availability of ICU beds, or would something further need to be done directly related to those ICU beds, which, based on what you're saying and the hospital preparedness dashboard, seem to be the ones that are in the most demand right now compared to regular medical surgical beds?
Sure. So it depends upon what the quote-unquote elective procedure or admission might be. If the elective procedures was, for instance, a cardiac bypass surgery, the person would actually be in the intensive care unit. Many other electives would not require that. But it would use up hospital beds, and it would use up staffing, and those procedures do use up PPE. And so it all relates. And so what the hospital has control over are their quote-unquote elective admissions, procedures, et cetera. Some of those are more elective than others. And so we have already asked them to, within their hospital and their hospital system, but also within their healthcare region, to work collaboratively and to be able to adjust those admissions to make sure that not only for their hospital, but regionally, that there are enough staff and enough beds and enough equipment to be able to treat patients with COVID-19 and the acute and emergency patients that don't have COVID-19. And so many hospitals that have had staffing shortages or bed shortages have already adjusted their elective admissions to do that. What this order does is if a region is challenged for two of those variables, including staffing, which is the one that has been, the one that's been positive in two regions, that then they would decrease it for 50% throughout the region for 1 week as they work collaboratively to make sure there are enough resources.
And Doctor, the staffing shortages that you mentioned, particularly in the Southwest and the Keystone regions, are they because staff are getting sick with the virus or quarantining because of contact with someone, or are there other reasons for those shortages right now?
Mm-hmm. Well, all of the above. And so, there are staff that are being diverted to patients who have COVID-19 and in COVID-19 units. So there's in hospitals that have high rates of COVID-19 patients, there's a lot of staff being used for that. But also, as you said, there are staff that have COVID-19 and have to isolate at home, and hopefully they're doing well. And there are staff that have to quarantine. So there are many different reasons why there might be staffing issues.
Next up is Jim Millward from KYW News Radio. Jim, go ahead.
Hey, good morning, Doctor. Yesterday, Montgomery County Commissioner Val Arkush said that in the spring, when there were concerns about hospital availability, the National Guard was able to come to southeastern PA because it was more regional. But she said that's not really an option now. Wondering if you can elaborate on the strain or the availability of the National Guard and what role they might be able to play or what role they are playing right now as this unfolds.
Sure. Well, we would certainly offer our thanks to our really courageous National Guard members who have been deployed throughout the COVID-19 pandemic and the emergency. Right now, actually, we have multiple teams of National Guard, and they are working with us in the long-term care setting. And so it's not, they're not really available to go into hospitals because they're fully employed and fully deployed to nursing homes and other long-term care facilities that are challenged. And so they can't be in two places at once. And so right now, that's their mission.
Thank you. Next up is Tyler Pratt. Tyler, go ahead and unmute.
Hi, Dr. Levine. Thank you for holding this conference today. I have a question in two parts, and I will give you the first one. First, it is Dr. Jerry at St. Luke's here said the number of available ICU beds listed on the state's COVID dashboard isn't an accurate representation of what's actually available. So for local regions trying to track hospital beds, what does the data actually reflect?
Well, there's, I'll have to talk to Dr. Jarrett in terms of the specific numbers he's referring to. But we have a certain number of licensed intensive care unit beds in the state, and we know that number. But actually, hospitals have been converting general medical surgical beds and other units as intensive care units, adding the equipment and the staff to do that because they have to take care of COVID-19 patients and then other intensive care unit patients. And so there are times where there are actually more beds than our quote-unquote licensed beds. We know that, and we've approved that. So that might account for that discrepancy. Hospitals have been diverting other beds to intensive care unit beds to take care of the load.
Thank you. And just as a follow-up, thinking about a vaccine, he says that we could begin distributing the vaccine around December 15th. So how does the state rule who gets the vaccine line up with federal guidelines?
Sure. Well, you know, all of this is evolving at very quick speed. So in terms of Operation Warp Speed, so I guess that's appropriate. In terms of the priority list, there was a meeting from the Advisory Committee on Immunization Practice, or the ACIP at the CDC earlier this week, and they put forward some recommendations. Their written recommendations will be coming out soon. Now, of course, the Pfizer vaccine will go first to the FDA on the 10th. We will await the FDA's official declaration that this is a safe and effective vaccine to distribute and administer, and then we will be doing that. So Operation Warp Speed will be delivering the vaccine, the Pfizer vaccine, to hospitals and health systems in Pennsylvania that have the capacity for that storage and administration. That's the one that has to be stored at minus 80 degrees centigrade or Celsius. And then we stand ready to work with them on the plan to deploy and administer the vaccine. Those will be going to healthcare workers, and healthcare workers in a broad definition. And then as part of also part of Phase 1A, when the vaccines are available, they'll be going to Walgreens and CVS for distribution to immunize the staff and the patients in nursing homes and then other long-term care facilities. About a week after the Pfizer vaccine goes to the FDA, the Moderna vaccine goes to the FDA, and then we'll hope for that approval, and then we'll work to distribute that also to hospitals, and then through CVS and Walgreens to those long-term care facilities.
Next up is Samantha Galvez from Fox 43. Go ahead, Samantha.
Hi, Dr. Levine. You said a third or more of the regions could be anticipating staffing shortages next week. How does this impact people who have hospital needs that might not be COVID related, We've been told this whole time to not avoid hospital care if you need it, but could that change?
Well, we don't want people to avoid medical care, both outpatient and hospital care, if they need it. So if they need acute care, they should seek it. If people have chronic medical problems, they should definitely seek care. What the hospitals are going to have to do is to balance their resources to take care of both the patients with COVID-19 that require hospitalization, as well as the acute patients that don't have COVID-19. To do that, they will need to manage their quote-unquote elective admission list, either for elective medical admissions or elective surgical admissions. Some of those are really not so quote-unquote elective and have to happen for instance, a cancer biopsy or something. Others might be actually less urgent and can be postponed to save resources. So we have called upon over the last number of weeks for the hospitals and the health systems to work within their facilities as well as regionally to make sure that we have the capacity to take care of all the patients that are in need.
Next up is Brett Schultes from WITF. Go ahead, Brett.
Good morning, Dr. Levine. Can you hear me okay?
Yes?
Okay, thank you. I'm looking at the recent daily numbers, over 10,000 new positive tests, and I wonder what your data modeling going forward shows in terms of, can we expect to see this level off with the current mitigation efforts that we have in place, or is there reason to believe that the exponential growth will continue to increase, and at what point might it level off?
Well, as we've said all along, there are three ways to deal with the pandemic. Containment, that involves the testing and contact tracing that Director Huff spoke about yesterday. There are mitigation efforts, and we have increased our mitigation efforts over the last number of weeks. And then there's the distribution and administration of the vaccine, which I just talked about. Those are the tools in the toolbox. So we're going to be watching our numbers very, very closely, and we're going to particularly be watching our numbers in relation to hospital capacity and impact on long-term care facilities. It's hard for me to predict the future in terms of what mitigation measures might be necessary, but right now we're going to be observing the impact of the mitigation measures that we put in place. Modeling done by the IHME, or the Institute for Health Metrics and Evaluation at the University of Washington, as well as modeling done by Dr. David Rubin and his team at the Children's Hospital of Philadelphia, are very concerning about increases in the number of cases, increases in the number of patients in the hospital intensive care units, and then increases in death. So we're going to be working through with all the tools in our toolbox to try to limit the spread of COVID-19.
Dr. Levine, if I would just be able to ask a quick follow-up, at what point might any additional mitigation measures be put into place, and are there even any on the table at this point that would be feasible or workable?
Well, again, it's hard for me to predict the future, but we're going to be watching our numbers carefully. And I mean, in the end, we'll do whatever is necessary to protect the public health of Pennsylvania. But I certainly don't have any details at this time.
Next up is Seth Kaplan from ABC 27. Go ahead, Seth.
Thanks for taking the question.
Seth, we have some issues with your connection.
Talk some more about the kinds of things that in normal times, truly not urgent, and the cancer Pennsylvania right now was something rather important to take care of. If we don't avoid the overwhelming the healthcare system.
So you were breaking up a bit, but if my understanding correctly is what type of procedures are more urgent and need to be done now, and what type of procedures could wait. That is really up to a patient and their physician and their healthcare team to decide what would be necessary now and what could wait. But hospitals do have the ability to manage their beds and to manage their capacity and their staffing ratios, and we are calling them to do that to make sure that we have the capacity to take care of any COVID-19 patient or non-COVID-19 patient in urgent need of hospitalization.
Thank you.
Next up is Sam Rulin from the York Daily Record. Sam, go ahead and unmute yourself.
Hello, Dr. Levine. Thank you for taking my question today. Mine is in regards to the vaccine, and it might be a little premature, but when it comes to administering the vaccine to the general population and who it's kind of going to take to administer that as our healthcare systems are being overwhelmed and as staffing becomes a concern, is there going to be an issue when it comes to hospitals needing to have nurses and staff kind of now administering the vaccine? Will that take away their time that would be kind of direct patient care? And is there kind of an idea of how that's going to be balanced?
Sure. Well, you're exactly right. It's going to need to be a balance. Now, at the beginning, of course, we're not talking about the general population. General population is in phase 3. I can't tell you when exactly that would be. We might estimate that might be the end of spring to summer, where the general population will be vaccinated. That would most likely not be hospital personnel. We're going to be working with our pharmacy partners, many pharmacies throughout the state in terms of vaccination, as well as physicians and other providers in their offices, as well as federally qualified health centers, vaccine clinics throughout the state, for the general population. But you're correct, for the phase 1, for healthcare workers, that the vaccine is going to hospitals, and hospitals will be immunizing their staff and staff within their area, and that will require a balancing of resources. Now, Operation Warp Speed will be sending what they call the kitting, which involves the needle, the syringe, the swab, the materials necessary to administer a vaccine. So the key is actually going to be personnel, and the hospitals will need to balance that, and we'll work with them.
And then would there be any kind of scenario where we're seeing these 5 strike teams for administering the test? Would there be something similar kind of down that road when it comes to administering the vaccine?
Well, we'll see as we get to phase 2 and phase 3, whether we do have mobile capacity to be able to go to rural areas or certain urban areas to be able to administer the vaccine. That's very possible. That will not be how phase 1 is done, as I just described. But as we get to phase 2 and phase 3, that's an option.
Next up is Tom Ford from the Borough Newspaper. Tom, go ahead and unmute yourself. Tom, go ahead and unmute. Okay, thank you, Tom. Sam Zern from PLS is next. Sam, go ahead and unmute yourself.
Hi, Dr. Levine. Just a small question here. The CDC updated their guidance for travel restrictions, saying something between 7 and 10 days would be appropriate post-travel. Is the Department of Health looking to change their guidance at all related to 14 days of quarantine post-travel?
So you're talking about the general quarantine guidance. That's not just travel guidance. That's the general quarantine guidance was updated by the CDC, and we will be working to align our recommendations with the CDC's recommendations. So it's not only for travel; it's actually all quarantine. So it would include people that are exposed. There are a lot of nuances to that, and so we're working through all the nuances in terms of the different options that the CDC gives us, and we'll be putting out specific guidance soon.
Thank you.
Next up is Mike Rubingham from the Associated Press. Mike, go ahead and unmute yourself.
Hi, Dr. Levine. Some modeling shows that Pennsylvania is on track to actually run out of ICU beds. Do you see that as a realistic possibility? And what happens then?
I see that as a significant concern that we need to work to avoid. And so that's why we have our metrics that we're following closely that are on our dashboard. That's why we have the order in place in terms of elective admissions if 2 out of 3 of those metrics are triggered. So we're going to work to avoid the scenario that any specific region or, of course, the state quote unquote, runs out of ICU beds. I mean, there's lots of, as I mentioned previously, there's lots of ways to increase ICU beds. You can turn medical surgical beds with the right equipment into ICU beds. More than the bed is often the staffing. And so we're going to need to work with the hospitals and the healthcare regions to balance staffing to make sure that that doesn't happen. But for the public, for you, it is so important. We have a significant, in fact, you might argue, the most important role to play. And that is why we are asking you over and over again to follow our basic guidelines. Please wear a mask when you go out. Wash your hands. Social distance. Avoid large and even small gatherings, even during the holidays. And that's why we have our stay-at-home advisory. If you do not have to go out to the grocery store or the pharmacy, please stay home. By staying home within your household, you can help us avoid that scenario where we could potentially run out of beds and staff.
Right, and you can't create staff out of thin air. And so if you come to a point where you kind of run out of staff, I mean, could we see rationing of care eventually in a worst case scenario?
Well, we're going to do everything we can to avoid that, and you can divert staff. I mean, you're right, you create them. We can't just, staff are in incredible need throughout the entire country, so they would have to be diverted from one area or one hospital to another area or another hospital, which then, potentially puts other care at risk. And so that's why it is within our power, our collective power, and if we stand united and follow the guidelines, we can prevent that from happening.
Next is Paul Go from Pittsburgh Business Times. Go ahead, Paul.
Thank you, Dr. Levine, for taking my call. I'd like to know a little bit more specific about what's going on in southwestern PA. You talked about within the next week, the staffing trigger would be pulled. What does that mean? Is that the only one right now that's under watch or close to that 50% elective surgery reduction that you're talking about?
So there are two regions that have staffing concerns, the Southwest and the Keystone region, which is South Central. But in both regions, they're the only metric that is close, that is of concern. The other two metrics are stable at this time.
And on Mike's question previously too, what is that next step because staffing doesn't come immediately? The staffing is what it is. What can be done? What can you tell the residents of southwestern PA and the
Sure.
Keystone region?
Well, staff have to be diverted from one area to another area. For example, we know that some hospitals have had to close cardiac rehab units, where cardiac patients who go there for nutrition advice, for exercise, and things like that are closed. And those staff have been diverted to more med-surg care, and then other nurses and other staff have been diverted to the intensive care unit. So, hospitals have the ability to divert staff from one area to another, and hospitals can share staff, if they absolutely have to as well, within a region. So we really consider the regions as teams, and the hospitals and health systems have to work together. But there is a point where that is straining, the healthcare system, and we have to make sure that we don't get to that point, which is why I call upon everyone to stand united and work together to stop the spread of this virus.
Next up is David Winter from Penn Live. Go ahead, David.
Thanks, Dr. Levine. This has to do with the trigger for staffing level. How do you actually know what the staffing level is within individual hospitals or systems? I mean, is it pretty much a self-reporting thing? And how much insight or how much knowledge do you have about things such as perhaps excessive overtime going on, or even ratios, staff to patient ratios that aren't what you would like them to be? I mean, how do you really know?
Well, this is a self-report from the hospitals, but we have an excellent relationship with our hospitals, with our healthcare coalitions, with the hospital association. And so, we trust the data that they send us in terms of their staffing. And we get reports from them when they have to do things that are not usual not usual in terms of regulations, like having patients in the hallway or having to a patient has to stay in the ER a longer period of time and things, and whether they have to divert staff. So we get all of those reports from the hospitals and we follow them all really closely. And we trust the hospitals. I mean, we're all in this together, and we trust their data that they are sending to us.
Okay, and if I could, I would just like to ask you about your confidence in the supply of healthcare workers. I ask that from the point of view that the agencies, we know they exist, but I imagine they're under tremendous demand right now, or at least potentially under tremendous demand from everybody. And we also know this is going on virtually in every state. I'm trying to find out how much of a cushion in staff you believe might actually exist, and what your level of concern is that there eventually might not be enough.
Well, we have a significant level of concern about the amount of staff, because you're right, it's not infinite, and other contractors that they might work with, are in need. Those staff are in need throughout the country, and so this is a national emergency. And really, we need national leadership to be able to address this. And we need, within our state, all of the hospitals to work together to make sure, especially as we have in our regional coalitions, to balance the staffing needs. And that's why, as I've said before, we all need to stand united and work together to stop the spread of the virus. And so this is a very, very significant issue. And even for people who say that they haven't seen anybody with the virus or they haven't seen anybody very sick, that's wonderful, and I'm glad they're so fortunate. But there are so many people who are not so fortunate. And we hear that the information, for instance, from the doctor from Geisinger all the time. I hear from physicians and from hospital leadership all the time, and our quality assurance staff hear from the nurses and other staff about how strained the hospitals are. And you can see from other states what happened in New York and New Jersey, for example, in the spring, what happened in Florida and Texas and Arizona this summer, what happened in Wisconsin, North Dakota, South Dakota over this fall, how difficult it can get. And so that is why we have these messages that we're putting out so we can all work together.